Okay. Volta region, 13 cases from Ho, Agotime, Jope, K2 North, and Chanto region, 41 cases from Asqua municipality, which is now the hotspot for the region. Obuasi 7 cases, Kumasi Metro 1, Ejoso 1, and Mampo 1. Saboba, Northern region reported 9 new cases from Saboba, and Savannah reported 2 cases from Central Gonja. Bono East, 9 cases from Pro East, Techiman, and Upper West region, Upper East, Northeast, Oti, West North, and Bono East, Bono region, and Ahafo region did not report any new cases. Your Honor, the Minister of Information, distinguished ladies and gentlemen, this is a situational update on the case count on COVID-19 for the country, Ghana. Thank you very much.
Thank you, Dr. Bedu Sarko, the Director of Public Health at the Ghana Health Service. I want to invite the Director General of the Ghana Health Service to explain to us what this amended discharge policy is. There's been a lot of work, you inform us, that has been going on looking at the data of how the virus manifests in people and the kind of risk levels associated with that. And based on that, you have decided to amend the discharge policy. If you can give us first a background and explain to us what this amendment means.
Thank you very much, Honorable Minister. Good morning, ladies and gentlemen. I will just be, as the Minister for Information said, I will take you through the policy decision, the rationale, and the evidence behind the policy. As you saw from Dr. Bedu Sarko's case, you can see we have a significant number of people, active cases, as whether they are really active. Active cases also mean that these are the people we need to worry about, we need to take care of. And so we need to really properly define them. We also know about the recent concerns, though not wholly true, about the congestions in our hospitals and isolation centers. These have all created part of it. But Ghana's discharge policy was started from March when we started having our case, and those was based on the WHO guidelines, which was published, an interim guideline published in March 2020. In those guidelines, it was more of a test-based strategy, and the patient was discharged after getting 2 negative PCR tests within 24 hours apart. Initially, because the numbers were few, this was an adequate policy, but with an increased number of cases, now we are talking about 12,000 plus, it brought to fore some challenges, and not just Ghana, globally everybody started having a challenge. First was the rising cost of tests. I've already told you that the test is not as simple as we make it look. It's quite expensive. We also talked about the fact that because of that policy, each person who has had 10 positive had to do 3 tests to be discharged. That's your first positive test, your first negative, and your second negative. If you are lucky, you don't have repeated positives along the way. So you have a minimum of 3 tests. And if every test costs you so much, you see what takes you to. The increasing workload because people were staying in hospital just waiting for their results to be able to be discharged. That also had implication for sustainability, feeding, etc. And most importantly, the social cost to the patient who is not ill but is being kept to, as it were, stay awaiting a result. And so that was the last one. But new data started coming up. The new evidence is that the viral shedding and clinical presentation led to many changes in our policy, not just in Ghana, Singapore, the European countries, and WHO itself, among others. So on the 27th of May, a new release from the clinical management guidelines modified the discharge criteria. Let me also just pause here and explain the difference between discharge and recovery. They are not the same. Discharge means, as I'll go through, means that you are healthy, you don't pose a risk to anybody, and so you are discharged. But we'll go ahead and see that you have tested negative, and then pray that you are viral. But I'll give you the symptoms there. So the new criteria combine time-based and symptom-based strategies. That's the duration when you were contracted up to the time, and also what are the symptoms? Are you still coughing? Do you have fever, etc.? These are the two combinations that that is more that helps us. For cases being discharged after a period of time and symptom-free, that is for those who are not showing any symptoms. The period of time is the initial after the initial test was done. So basically, we have the time-based. That is those who are not showing the symptoms. Is about how long was he tested positive and how long is it now. And for those who are symptoms, are they still exhibiting symptoms after a certain duration of time? That will determine whether we discharge them. So based on that, WHO in that guidelines made two recommendations. For symptomatic patients, that is those who have exhibiting either cough, fever, who are sick, for say, 10 days after the symptoms of onset, plus at least 3 days without symptoms. So 10 days from the positive test was done, up to the time that you have 3 days, a minimum of 3 days. So if you, after 10 days, you are able to show that no symptom for the next 3 days, you are discharged without a test. For those who do not have symptoms, WHO recommend that for 10 days after initial positive test, you should be discharged. There are new evidence that we can show. Evidence of many studies have shown that they continue to shed virus from the upper respiratory tract, that is from the throat, nose, etc., approximately 7 to 12 days. And irrespective of the number of the viral load, after a certain period, they do not shed. In Ghana, our own case management team had followed about 146 patients, and all of them had tested. The average time for testing 2 negative was 14 days. So in view of all the evidence that is coming out across the globe, we decided, with all the context that I have, to review our policy to reflect the new trends and also decongest our place and also allow us to focus more on the sick. So we, as a service, met all our directors and other stakeholders, other scientists were consulted, and these were the new protocols that we had agreed to. That for patients who are asymptomatic, that's, for example, somebody in PCC, etc., if you are admitted to the Pentecost Convention Center or any of our isolation centers, 14 days after the initial positive. The initial positive is not when you receive your results. It's the day your sample was taken. Because that is when you were positive, not when the results came. 14 days after that, we will discharge you without a test. For those who are symptomatic, we do 14 days after discharge, and then if you are without, after the testing positive, if you are without symptoms, you are discharged. At least 3 days of no symptoms, you are discharged without a test. What we will do is that then you'll be asked, because you don't pose any threat, you'll be now doing your negative test on the at home, and then come for review, and we'll see that. So that's when that will do. So when we have reviewed that, you realize that quite a significant number of people who still remain on our books because their lab results are not in, they will all be discharged unless they have conditions. So basically, this is a new policy. So the policy is at 14 days for asymptomatic cases. From the time that you are tested, you took your sample, you'll be discharged. So if I was sent to, they took my sample on the 1st, I probably got my results on the 3rd of March. I moved to PCC on the day I arrived. I know that on the 14th of June, I'll be going home. And you have some predictability as to when you go. For those in hospital, and usually within 10 days, symptoms abate, and then we'll do 3 more days. If you remain stable, then you are discharged. And we hope that will also help us, allow us more time to focus on the new cases, be able to give more attention to those who are newly positive, and then also create space in our facilities to be able to take care of more cases, which we really do not hope that we get. Thank you very much, Mr. Minister.
Dr. Baji, thank you. So if I understand you, we haven't amended the recovery definition. What you have done is to amend the discharge policy in line with WHO guidance and then the local evidence. Correct?
Yes.
Okay. All right. Colleagues, we'll take your questions at this point in time. I want to make it as quickly as possible because we've already spent some time. So if you have questions. Kojo? I have 3 here. Do I have any other takers? Yes, sir. So do I have any other takers? 5. And should I wrap up after these? Okay. So I'll wrap up after these 5. Yes, Matilda, I'll start with you. Let's space out, please. Yes.
This discharge policy that is being amended, what is the plan like? Is it going to isolate some number of days, or you can live his or her normal life whilst living with the family, congested or are full? So people, even in the Greater Accra region, are being transported to places outside the region. Please, thank you.
Thank you.
Television. I have a quick one on evacuation charges required of the UK evacuees. I'd like to know if government has a subsidy for Ghanaians who are...
I'll take that one. Let's go.
My name is Kujajman. I work with CTTV. I just want to find out that has the number increased? Just you can mention them for us. Has the number increased? Because right now we're getting a report from the Ashanti region that some centers are full up. Therefore, they are calling on private medical health facilities to come and join. And we also want to know they should pay for their upkeep to cater for these people. So,
Honorable, good morning.
Went for funds for the management of isolation and treatment centers, or government went for funds
money for upkeep of persons who will be quarantined and isolated, which includes people who come from outside.
Include. So
yeah, that's
okay. So pay for the upkeep of evacuees. I think that's where the question. Okay, thank you, Kojo. Yes, sir.
Honorable, good morning.
Morning.
Femi Jesse.
I will say a payment for.
Okay. Good morning, Honorable.
Yes, madam.
Femi Opoku, mi free kingdom FM.
Oh, yes, sir. Go ahead.
Pastor, my question here, you share a free Ghana Health Service for website, so omomu new death na be count no. You share be na say birth was for below 40 years. Mr. Bako kwampo ho we no oni any underlining yare bia man we. See person find out DNA course no and I say virus na nuguchi focus on master the way and the subainti no. See wasanse sa the new direction na ma cause this new data without any underlying sickness and
Okay. Thank you, colleagues. We'll wrap up the questions here and then provide answers. Let me quickly take the 2 that require government responses. Is there a government subsidy for evacuees? No, I do not have a brief to the effect that there's a government subsidy for evacuees. There are conversations about means in further conversations with the operator ongoing. But I do not. The second matter is that I am not aware. I think what we are aware of is that government went for money to provide for isolation. They are moved into isolation centers. That doesn't come at a cost, or their upkeep is not at their expense. But for evacuees, apart from the category of evacuees who have been determined as destitute, who were sometimes living on the streets or who had been sent, let's say, by government to programs, etc., who have been assisted by government to come back voluntarily. They are prior info before they are given tickets that they are willing to buy. I am not aware, I don't have a brief to the effect that voluntary evacuees, people who are not destitute, people who are not, let's say, from any government program that are being brought back, voluntary evacuees. I'm not aware that government has gone for money from that have accepted to accommodate them and the cost associated with it. And they choose their facilities and inform the authorities of saying before they are given, there's room to engage with the providers of those facilities to do something about the cost. Is something that remains under consideration. So I want to come to Dr. Abadi to help us with some of the questions.
Thank you very much. The first question is about what we do with those we have discharged. The very reason why we isolate or we quarantine is because you have because you are not able to share the virus. You are unable to transmit to anybody. So you go home as a free person. And so we are doing discharge because eventual recovery protocol, and that's why that will be done on an outpatient basis. Now, the places. I mentioned that capacity for 600 cases. The highest we ever got in a particular day was 580 because we have moved some people from, we have just about 360 people there, so it was wait for results. It's important, and so we will need to look at, apart from the cost to the state, there's also a cost to the person. And so with this evidence, there's no point in keeping anybody beyond that period, especially when they are asymptomatic. In a place like Kumasi, but one of the reasons is that there are also people in those few sites who are waiting to have their recovery by the protocol before they are discharged, even though they are not a threat to any. So the social cost to the patient. CTFM. Yes. You see, in any hospital or clinical setting, there are days that you are going to have a few more cases than usual, and there are days we are not. From what we are seeing, we are not seeing any persistent surge in any case. There could be a 2-3 days that you can have a few cases, and the next 3 days you have no case. And so if you look at the trends, which will be sharing very soon, we are not seeing any surge per se, apart from Ashanti region, where we felt that the number of beds there were fewer for the number of cases. But even this new policy will help free up a lot of space.
Yes, but the question is specific. Has there been
an
increase in the number of facilities?
Yes, I'm going to go there. I'm here to get to that one. That's the city of... We started with 33 centers when we started the response. We had 50 beds allocated for them. Treatment from 450 to 700. As you remember, I showed the 450 here. Now we have 700 beds across. Of the 71, 20 are technically closed because those regions do not have any case. The Bolga had people there. They've all been discharged. So nobody, so we have 20 isolation treatment centers that are currently not being used. So that's where we are. So, and that's the situation. We are still going to have additional numbers. We are creating additional 12 ICU beds in Rage. There are additional ones going to be, especially in Accra, the Pantine area, Dodowa. I think so. the city wanted to, I don't know whether I should, okay.
Just before you wrap up, if you indulge me, so what specifically are you doing with the Ashanti region situation now? Yes, the medical director there announced that the situation is getting out of hand. So what immediate steps are you taking?
Yes, even before the statement, we have new beds in Suntreso that we are going to east so that we can have the cases done. For pregnant women and medicine mothers, the protocol is very simple. These protocols of social distancing, hand hygiene, and the wearing of masks protects everybody, whether you are at home or at work. We do not have any good reason to say pregnant women should stay home or not, but these are corporate policy that if you feel that you may want to have some change, but we expect that all of them will go through the needed protocols to protect themselves and their children. And so we do not have the initial stage where we were decongested. But if you are doing social distancing in your workspace, and you may have to sort of let some people off, more free time, you may, those pregnant women whose risk levels are higher, you may decide that you can let them go and have some more time off. So thank you very much.
Below 40 deaths.
Yes. Yeah, with the case, Mobility, I'd like Dr. Bedusa Akodie to respond to the last question on there, and they give more explanation on the deaths.
My understanding to the question, there are people that are within the lower age bracket, few of them that have been succumbed to the virus and died, and then not with comorbidity, and that is the virus changing itself to be more aggressive or more virulent. We have to take the situation in totality, the entire concept. All the cases that we have are the people that are dying, the younger age group, those with or without comorbidity. And that's the context that you have to look at this. And not within the box, you pick one case and use it to describe the situation and indicate that the virus is getting more virulent or more aggressive. So looking at the total picture, the age, those people at the higher age group, and then those with comorbidity are those that are more at risk of severe disease, at risk of critical condition, and then also at risk of dying from the virus or the infection. So there's no evidence now to indicate that the virus is changing itself if you look at the total picture, the entire picture that we do have. And you have individual differences. Some, ordinarily, the older you are, the most likely or the risk of having a more severe and then critical condition that probably could lead to death. However, you have individual differences, and some people at a quite young age group could also die out of it. So the youth should not think that those to have severe illness, critically ill and dying is for the aged. Everybody can have it. Those without comorbidity should also not think that I have no hypertension, no diabetes, no other condition, so even if I have it, I have no risk of severe disease. So clearly, everybody, depending on the viral load that you happen to have, you can still have now that the virus has changed itself, and that the people with comorbidity are most likely or most at risk to have severe illness and then suffer death. But then anybody can also, as an individual, based on your makeup can also suffer some of these extremes. Thank you very much.
Thank you very much. Just to top up, one of the challenges we are having is that people are coming late. The disease has a natural cause, and those we see early recover. Even the number you see as critically ill, of stigma, some people stay home. They don't want anybody to know their positivity, and then they come in late. If you are young, if you are old, be managed. And so we are appealing that people should report early. Those who report a significant number come in and die within 24 hours. People should come in early so that they can be saved. Thank you very much.
Thank you, Doc. Colleagues, as we wrap up, we'd like to reiterate the government's call to heads of regional and district coordinating councils that the executive instrument that makes the wearing of masks mandatory is out, and not that the EI is out, and they are expected as regional ministers, as MMDCs, to step up enforcement within if people are wearing it. Those who have a viral presence in their system will not be able to spread it to other persons. We should be each about 19 ministers press briefing. Thank you.